All right, let's get right into this explainer. Today, we're rigorously mapping out the complex world of endocrine feedback loops and exact diagnostic thresholds. To truly master clinical endocrinology, you have to understand the kinetics of these master hormones, how they talk to your organs, and, most importantly, how they behave when the whole system breaks down. So let's dive in.
We've got a hyper-dense curriculum lined up today. We're running rapidly through adrenal kinetics, hitting the Cushing's fork, dissecting thyroid dynamics, reviewing calcium physics, and finally tying it all together with clinical reconciliation. We're skipping the basic fluff and going straight for the granular physiological boundaries that define real-world diagnoses.
Let's kick things off with adrenal insufficiency. What's genuinely fascinating about adrenal kinetics is how precisely we can pinpoint a failure location just based on pituitary signaling and autonomous kidney pathways.
The absolute key differentiator here?
It's the mineralocorticoids. Think about it. Primary adrenal failure, Addison's disease, means the entire adrenal gland is effectively destroyed. No aldosterone means severe hyperkalemia, hyponatremia, and a non-GAP metabolic acidosis. But secondary failure? That's an issue up in the pituitary. The adrenal gland itself is structurally fine, so the RAS system keeps aldosterone perfectly preserved. The result? Your patient's electrolytes are usually completely normal. And this is exactly why primary disease patients develop hyperpigmentation. It's literally a byproduct of a desperate pituitary gland cranking out ACTH to try and wake up a dead adrenal gland. The precursor molecule to ACTH is POMC. When the pituitary ramps up POMC production, it splits into both ACTH and melanocyte-stimulating hormone, or MSH. That MSH drives melanin synthesis. Bam! Hyperpigmentation in the mucosa, the hand creases, and the knuckles. You will absolutely never see this in secondary insufficiency because in that scenario, ACTH is actually low. So how do we prove this? Let's look at the diagnostic algorithm and the cosentropin stimulation test. Morning cortisol is step 1. It's not perfectly sensitive, but an 8 a.m. level under 3 micrograms per deciliter is a huge red flag. To actually confirm the diagnosis, you hit them with a synthetic ACTH dose, cosentropin, and measure the serum cortisol response at 30 and 60 minutes. Now, lock this threshold into your memory right now. A peak level failing to cross 18 to 20 micrograms per deciliter firmly seals the diagnosis of adrenal insufficiency. If you administer ACTH and the adrenal glands still can't produce cortisol above that mark, the factory is fundamentally broken. Oh, and a quick clinical caveat. If your patient is in acute adrenal crisis with shock and dehydration, do not wait around for this test. Treat first with IV steroids and test later. Moving right along to the Cushing's fork, we are pivoting from adrenal failure to the exact opposite problem. Instead of too little cortisol, our patient has entirely too much, presenting with classic signs like a buffalo hump and proximal muscle weakness. Before you even think about hunting for a lesion, you've got to prove the excess cortisol is actually there. Cushing syndrome just means too much cortisol. It doesn't tell us where it's coming from. So confirm it first using one of these primary screening modalities: a 24-hour urinary free cortisol, a late-night salivary test, or a 1 milligram overnight dexamethasone suppression test. All right, hypercortisolism is confirmed. Now, checking plasma ACTH becomes your primary compass. Low ACTH, it's coming directly from an adrenal tumor or exogenous steroid use. But if ACTH is high, you hit a crucial fork in the road. Is it an ACTH-secreting pituitary adenoma, which is Cushing's disease, or an ectopic source, like small cell lung cancer? This brings us to the high-dose dexamethasone suppression test. This is brilliant because it perfectly exploits feedback sensitivity. Think of it like this. A pituitary adenoma is basically normal tissue gone rogue, right? But it still remembers the rules of negative feedback. Hit it with a massive 8 milligram dose of dexamethasone, and it will temporarily suppress its ACTH production. But an ectopic tumor, like lung cancer, it is completely autonomous. It's deaf to the endocrine system and will absolutely not suppress, no matter what you do. So the big takeaway here? A complete lack of suppression with high-dose dexamethasone immediately forces your choice architecture toward a chest CT rather than a pituitary MRI. It's a perfect example of how relying on physiological feedback loops literally dictates your anatomical imaging.
Into thyroid dynamics. Let's shift our focus to the neck to separate true hyperthyroidism from acute inflammatory states.
Look at the stark contrast here. Graves' disease is an active receptor-stimulated hyperthyroidism. Thyrotropin receptor antibodies are constantly hammering the gland. do a radioactive iodine uptake scan, and the whole gland lights up with diffuse uptake because it's actively synthesizing massive amounts of hormone. On the flip side, de Quervain's thyroiditis is usually post-viral. The patient comes in with an exquisitely painful neck, but the inflamed gland is literally just spilling preformed hormone into the blood. Because the gland isn't actively synthesizing anything new, that iodine uptake scan is going to show virtually zero uptake. And we absolutely must talk about the surgical red lines during a thyroidectomy. If the surgeon damages the recurrent laryngeal nerve near the inferior thyroid artery, the patient wakes up with hoarseness, or worse, acute area obstruction if it's bilateral. But what if they accidentally remove the tiny parathyroid glands? The patient loses their PTH and plunges straight into hypocalcemia. If a post-op patient starts having cramps or throws a prolonged QT interval, you need to check their calcium immediately.
And that surgical complication transitions us perfectly into calcium physics. Calcium regulation is tightly controlled, and mastering its physical properties in the blood is non-negotiable.
Literally never evaluate calcium without this exact formula. You absolutely must correct for albumin to know the true ionized state of your patient. Since a huge portion of calcium is bound to albumin, low albumin means your total serum calcium will look falsely low. You've got to add 0.8 milligrams per deciliter for every 1.0 gram that albumin drops below 4.0. Skip this step, and you'll end up treating a hypocalcemia that doesn't even exist on an ionized level. Now let's look at the feedback loops. Primary hyperparathyroidism gives you the classic stones, bones, groans, and psychiatric overtones. It's usually an adenoma, rogue-secreting PTH, which pulls calcium from the bones and dumps phosphorus into the urine. High calcium, low phosphorus. Secondary hyperparathyroidism, though, is most commonly driven by chronic kidney disease. The failing kidneys can't excrete phosphorus or make active vitamin D, causing calcium to plummet. The parathyroid glands respond totally appropriately by cranking PTH sky high to compensate. When that calcium drops, peripheral nerve excitability spikes, giving us some very specific, testable clinical signs. Tap the facial nerve and the face twitches, that's the Shopstick sign. Inflate a blood pressure cuff and the hand spasms, that's the Trousseau sign. Throw in some perioral paresthesia, tingling around the mouth, and you're seeing the direct physical manifestation of the electrolyte derangement we just calculated. Which brings us to clinical reconciliation. Let's tie all these metabolic boundaries together and apply the raw diagnostic data so we don't get tripped up by clinical red herrings. Think through this clinical scenario carefully, because the raw numbers dictate a very specific physiological failure. We have a severe hypercalcemia at 14 milligrams per deciliter, but the parathyroid hormone is totally suppressed down to 4. What is going on here? If you stick strictly to your diagnostic thresholds, you will bypass cognitive traps every single time. In our scenario, that suppressed PTH means the parathyroid gland is working perfectly. It's appropriately shutting down because of the massive hypercalcemia. So the calcium is coming from elsewhere. Given the lung mass, your brain should immediately jump to humoral hypercalcemia of malignancy driven by PTH-related peptide, or a direct bone metastasis. The feedback loop literally points you straight to the cancer. And one final error mitigation rule: never assume a normal potassium rules out adrenal insufficiency. As we saw earlier, secondary insufficiency preserves aldosterone, so those electrolytes will be totally normal. I'll leave you with this final thought to chew on. What seemingly normal lab value are you failing to evaluate in the context of its master hormone? In endocrinology, a single lab value is virtually useless in a vacuum. A normal PTH is actually profoundly abnormal if the patient's calcium is sitting at 14. An elevated ACTH means completely different things depending on whether cortisol suppresses with dexamethasone. You have to trust the kinetics, run the diagnostic algorithms, and always respect the feedback loop.